might just have half a beer. So you might think. I believe we're on page 6. Are we on page 6?
Yes. Yep.
A quick comment about bilirubin. I put something about how excess bilirubin in the blood can cause jaundice, and that there are 3 ways that can happen. I think in your book, like the last line of page 5, it says something like hemolytic, obstructive. Are you all seeing that?
Yeah.
You do not need to distinguish those yet. We'll do that later when we talk about the organs involved. Okay, so as much as I would be able to ask you about jaundice is what causes it, and that would be elevated bilirubin in the blood. Okay, so that's, say again? Or I might say, what color is it? What would you say?
Yellow.
Did I really have to?
Well, no, I was just asking if you would ask.
That would be fair. Okay, are we clear? I know, I never lecture. Anyway, let's talk about fluids, electrolytes, and acid-base concepts. Don't worry, this is not going to be as boring as the title says, but there are going to be some revisits for you all to do here. I think I've already said, be prepared for 3 or 4 questions on normal anatomy and physiology, and we've even kind of covered the topics I'm allowed to ask, like the heart, general heart chamber, valve, blood vessel anatomy, the meninges, that story about the hepatic portal vein and bilirubin and bile. Okay, and I think I left it there. Did I say anything else?
No.
I didn't say anything about the GI tract? No? All right. We'll do that later. Next unit, and for the rest of the units, I want you all to know, for any exam I want to ask, you all should know the names and numbers of the cranial nerves. How many of them are there? 12. Some of you might already have that down. Are they important?
Yeah.
Would I ask you to know them if they weren't important? You know, there was one year I had a patho class. I said this, and I hope nobody in this class did it because I didn't notice it. But a couple of years ago, or a few semesters ago, I said something in a patho class about you need to name and number the cranial nerves. And about 4 of them just rolled their eyes. Here.
What cranial nerve did they use?
Okay, that's what I should have said. See, if I was sharper, I would have seen it. But instead, I just got pissed off. And I said, really, you all are wanting to be healthcare professionals, and you're going to roll your eyes when I ask you to learn the cranial nerves. Now, you all remember the cranial nerves. 1 is olfactory, 2 is optic. These are quick to learn. And a cranial nerve exam, anybody ever done one? How long does it take? When you're good at it? It may take less than a minute. Seconds. A good nurse or physician could do it in a second. Does it give you a lot of high yield information like, am I worried about a central nervous system injury versus not? Yes. So they're really, really, really important. And the more you understand about the cranial nerves and how they work, the more you'll start to build on your nervous system, which I know whether you took my A&P or not, what did we all call Unit 3, the nervous system? The mother of all A&P units, because it was brutal. And that's why there's a lot of stuff. We'll take a little piece of that, the cranial nerves, and start learning them to the point where you can, I won't ask you this yet, I want you to know the name and number, but I want to start thinking, what is their function? A quick blurb about their function. Some of them, it's really, what's the function of the optic nerve? Yeah, vision, not moving eyes. So eyes is a little general, but vision, seeing. What about the olfactory? Smelling. So some of them are really, really straightforward. And then there's some that are complicated, like the facial and the trigeminal, and don't even get me started on the vagus. Okay, but they're really, really important structures. So when you get to a class like patho and your teacher says, learn this stuff from your basic A&P, go sink your teeth into that topic, come back knowing it, it'll pay off. It'll pay off. I know, I worked in healthcare. It's going to pay off. And by the way, I was a pathologist, but as a medical student, I'm ballparking this. I'd be willing to bet I did 200 cranial nerve exams. Just because I did a lot of trauma and acute care as a medical student. It's like, well, let's just rule out cranial nerve, get the student in there. Because students are supposed to do all the easy and boring stuff. That's what they said. So I learned it, and actually you really, when you see your first blown pupil that won't respond to light flashing in it, or your first hypoglossal nerve lesion where they stick out their tongue and it just goes to the left side every time, you start to learn about the cranial nerves. Let's not do that on this exam, but there's a little a hint as to a normal A&P that I'll add on the second exam.
So
Okay.
to worry about them.
No, not for this. Did I just say that? Yeah. Exam 1, meninges, heart, hepatic portal vein, and bilirubin. Let's focus on those. And of course, all this other awesome stuff in our handout. Especially the definitions. Anyway, fluids. Fluids. We are a bag of mostly water. Let's talk about where the water is. How we talk about the water. If I want to talk about all of your water or all of a person's water, total body water. That's it. That's everything. That's 60 to 65% of me. My total body water. Because that's how much of me is water. Then I can break that total body water down into categories like that water that is inside cells and that water that is not inside cells. We distinguish those as intracellular fluid and extracellular fluid. About a 2-to-1 ratio inside cells. So basically all your cells are little teeny weeny bags of mostly water. What is blood? Intracellular fluid or extracellular fluid? Extracellular fluid, correct. When I put a needle in, I'm getting inside a vessel, but not inside a cell. So blood is an extracellular fluid that we oftentimes get an idea of what is going on in you. Hydrostatic versus osmotic pressure. This brings back some memories. You all may remember this diagram from A&P. And we have the artery side and the vein side. So which way is blood going across this capillary? Is it going to your left or to your right? Everybody good with that? Okay. Is the capillary leaky? Yes. Capillaries are always variably leaky. There's got to be some leakiness to them. Where are your least leaky capillaries? Brain, did I hear? Did somebody say brain? That would be correct. Brain, why? Name why in 3 B's. Blood-brain barrier. Yeah, is the brain kind of special? Is it like the penthouse of you? Like not everything is supposed to go there? Have you ever heard of what do people with Parkinson's disease lack? Dopamine. Good. Where? In their fingers or in their brain? In their brain. If it was in their fingers, it would be a lot easier for me to dose them the dopamine they need and get it to their fingers because there's no blood-brain barrier to get through. But since I need to get dopamine into their head, I need to give them a higher dose than I think, and I've got to be really careful looking for their response. I want enough to get through the blood-brain barrier, but I don't want too much. What is one condition that you can get if you have too much dopamine in your central nervous system? Schizophrenia. And if you have never seen that, you will remember it when you see it. It is awful psychiatric disorder. So there is oftentimes a balance because of the blood-brain barrier, treating Parkinson's but don't overtreat it. And of course, the other side of that, what if I treat schizophrenia too aggressively? What am I giving them? Parkinson's. And it's really, really common with a lot of psychotropic drugs that we give for, say, delusional disorder or schizophrenia to cause a Parkinson's-like syndrome. Got to be on the watch for it. Anywho, where are your leakiest capillaries? Anyone know? Not quite. Well, you're in the neighborhood. What organ can handle it? The liver is the leakiest. Remember, you've got your vein blood from your digestive tract, artery blood for the liver. They all get mixed up. Very leaky capillaries. No matter how leaky your capillaries are, if I push fluid through this tube, is some of it going to squirt out? And by the way, what lives here? Cells. Those are just cells. Those are your tissues. So if I push fluid through this capillary, some of that fluid is going to ooze out my little leaky perforations there. Does that make sense? Okay, all that is hydrostatic pressure. I'm pushing. Push, That's what hydrostatic pressure is. It's a mechanical force. Push, push, every second. Push. What am I pretending to be? Push. Not blood, but the heart. Yeah, the heart. Yeah, that's what pushes, right? The heart provides this hydrostatic pressure. If your heart isn't beating, is your blood flowing? That's one of the reasons we want your heart to keep beating. Okay, and with a, let's say, a 115/70 blood pressure, I'm pushing it right about the amount to ooze out just the right amount of plasma into my tissues. But if my blood pressure is really high, bless you, like 165/115, am I pushing harder and pushing harder? Am I pushing harder? Am I going to push more plasma out of my leaky capillaries? So what that is that is a hydrostatic pressure being increased, and when you increase the hydrostatic pressure in this tube, you're going to push more fluid out. Do I want to push a little fluid out? The amount that would be pushed out at 115/70? Yeah, this is what makes this topic so tough. We look at 4 pressures here. We have 2 hydrostatic pressures and 2 osmotic pressures. Osmotic is the pressure of concentration. Okay? And the problem with this topic is that this is a kinetic system. Everything is moving. When I'm healthy, I'm at a balance of 4 pressures that have the right concentration of stuff in my blood. I'm pushing the right amount of plasma out into my tissues, and the right amount is getting sucked back in. And my waste is getting removed, and I'm oxygenating, and everything is moving really smoothly. Okay? So when I'm healthy, I have a hydrostatic pressure. It's my blood pressure. Do I have an osmotic pressure in my blood? Or is my blood pure water? Is my blood pure water? No, you all knew that. So do I have some stuff in it? Like, I don't know, magnesium and sodium and chloride and stuff? Does that give it a concentration? So if this is pure water, what effect would this have on pure water? It would attract it. So if I had a lot, I just ate like pizza with salty cheese and salty pepperoni and salty sausage, and anybody else getting hungry? High sodium. I got a lot of sodium in this. Is that going to pull more water in? Okay. What's that going to do to my blood volume? What's that going to do to my blood pressure? So this is exactly why we don't want people with high blood pressure to add sodium to their blood. That might pull water out of them into their blood and make their blood pressure go up. We don't want their blood pressure going up. We want it going down. Understanding these pressures, it takes a few coats of paint. Okay, so we just looked in the blood. I did a hydrostatic pressure in the blood, the pushing of the heartbeat. And I did an osmotic pressure in the blood. That's a little crazy how many dots I put there. That's just ridiculous. But at least it serves the point. You see that this high concentration will draw water in. Well, what if my osmotic concentration was high out here? What's that going to do? Now that will pull water out of blood into my tissues. Okay, these are the same pressures we talked about in your beaker with the divider and simple diffusion and osmosis. A lot of it just makes sense. You've just got to see how it fits in a kinetic system like the human body. I have a concentration to my tissues, I have a concentration to my blood, and I have a blood pressure. So all 3 of those pressures, which you all seem to visually be okay with, are at a balance in me. If I throw one off, if I all of a sudden decide to dial up my blood pressure to 200/150, now the other 2 pressures staying the same, now the hydrostatic pressure has been turned up, it's going to change my whole metabolism in this area. I'm going to be pushing fluid out. I'm going to be swelling up like the Michelin Man. Or something. Is the Michelin Man swollen? Is that right? Yeah, Michelin Man. Right? Good. Thanks. I had the wrong tire there. I don't have Michelins. I just know the Michelin Man. More expensive. Anyway, everybody got that? There's one more pressure to talk about, and the weird thing about this pressure is that it doesn't even exist. And that is the hydrostatic pressure here. Do I have a pump in my tissues pushing? I don't. In fact, what really is the case in a healthy person is there's a little bit of a suction force in your tissues. The hydrostatic pressure is actually negative. Like there's a pressure pulling water out, helping your hydrostatic pressure in here push it out. Okay? The problem with that pressure comes not when you're healthy, it comes when you're sick. Let's say this could be any tissue. Let's say this tissue has a lot of edema. That's fluid. Here's some more fluid, and here's some more fluid. Okay. If you go down to the bottom of a swimming pool, what happens to your ears? Yeah, you feel it. They start to pop. As long as that swimming pool is 6, 7, 8 feet deep at least. Okay. Why? From what? The water. You're under a lot of water. Do you all know that we have never explored the depths of the ocean? You know why? Yeah, we don't have anything we can send down there that won't get squashed under 7.5 miles of ocean water. We can go about 4, maybe 5 miles deep in those. Have you ever seen those little, like on the Jacques Cousteau show, they used to go down in this little sub, and I'm like, oh my God, it's a suicide mission. One little crack and you're dead. Dead. It was a squish. Fascinating. Anyway, have fun. Is this going to cause pressure? Yeah. Is this going to kind of push back? Yeah. Push back? So when my fluids want to get out of this capillary, is it harder? Yeah. It is harder, and it's harder. Okay, so now I've thrown off my pressure balance. So you can have hydrostatic pushing pressure in the blood, you're supposed to, or in the tissues, not really supposed to. And you have an osmotic pressure, both in your blood and in your tissues. It tends to be a little higher in the blood, so that as your plasma flows here and a little bit gets pushed out by the heartbeat, can you feel the heartbeat as well over here? The pushing is a lot less here. I'll show you why that happens in a minute. But now you want to draw some of that fluid back in, so you want your osmolarity in the blood to be a little bit higher. Here's what I want you all to take home from this discussion. I want you to understand which way these pressures will push or pull fluid. Okay, if I, for instance, say increasing osmotic pressure in the blood vessel will do what? I want you to be able to tell me it will attract fluid into the blood vessel. But if I decrease osmotic pressure in the blood, what will that do? Will that have the opposite effect? That will have the opposite effect. That means my blood is more dilute, so water is more likely to go this way, following its concentration gradient. Okay? If I increase hydrostatic pressure, that was when I went from a blood pressure of 115/70, a perfectly normal blood pressure, to 165/110, or whatever I said. Does it make sense? I'm going to push more fluid out of the blood. Okay, well, what if I go from a 115/70 to 90/40? I'm going to push less fluid, and really the way to say that is fluid will be attracted into the blood because there's less force pushing it out. Okay, and believe it or not, as confusing as this is, we deal with this concept in patients of all varieties, and usually it is nurses that deal with stuff like this, like edema and getting fluids off and making sure they're on Lasix when they need to be on Lasix, not getting sodium when they don't need to be getting sodium, managing ins and outs, checking for pitting edema, things like that on a daily basis in some patients, whether they have lung disease or liver disease or kidney disease. I'm just saying stuff now, I should show it off. Okay, really important. So don't feel like, I'm not going to try to bury you under this concept. I'm going to ask you a question or two about these pressures and what effect changing them will have to fluid in the blood vessel. And if you're at least comfortable with that, great. We'll build on it a little bit. That is the yes.
So, if you've got too much salt in your blood, and that means that the water in the cells is trying to get into the blood vessel, but you also have high blood pressure, is that what, compensating then? Is anything gonna be going anywhere?
Eventually what happens is you have the high blood pressure pushing the fluid out, okay? More fluid out than is supposed to go out, okay? Now, some of you may remember from your A&P, we don't recover all of that fluid. A little bit of it goes into the lymphatic tree. But the more I pump out, the less I recover, meaning this stays highly concentrating, still drawing fluid back in, increasing blood pressure. What it is, it's a maddening cycle. This volume always stays high, but parts of your body become edematous. And in fact, if you've ever known anybody with poorly controlled high blood pressure, the places the edema tends to be is the bottom of their feet and in their lungs. And we also oftentimes call that congestive heart failure, because fluid is getting into the lungs and there just isn't adequate return to get it out. It's a balance. It's all about breaking the balance. So you're thinking about this in exactly the right way. And sometimes I like to draw everything like a square house with 4 rooms and a curl of smoke, and it's perfect and symmetric, and it isn't that way. There's a balance of all this stuff. Okay, that covered the lines about hydrostatic pressures, osmotic pressures. I'll stick with my terminology. You don't need to know the term oncotic. Does anybody know what that means? Oncotic is the concentration of just proteins. Osmotic is the concentration of everything in your blood, which I will speak in terms of, but oncotic is just proteins. And then the balance between these pressures and any alterations in that. Like I said, be able to tell me the effects of increasing or decreasing a hydrostatic or osmotic pressure somewhere. Ions. Yes? Well, here's really what a blood vessel looks like with your blood in it. It has a lot of proteins in it. It's got red cells. You see how big they are compared to the proteins? Okay? And then there's some hormones. Okay? And then there's like some other just mediators and messengers. And then there's like sodium and chloride and magnesium and glucose. Tiny stuff. Okay? Everything I've drawn in here except the red cells gives my blood a concentration. What oncotic means is what concentration of just the P's do I have, just the proteins. And the most abundant blood protein is albumin, the one that you mentioned. So if my oncotic pressure is high, that's saying my sodium's normal, I just have too many proteins in my blood, and that probably means I've got too much albumin. Answer your question?
Sometimes people give albumin for edema.
Okay, now if I put a bunch of albumin in here, what's that going to do to the osmotic pressure of my blood? Is it going to go up or down? Up. So what will that do to the water here, which is edema in my tissues? Okay? And a lot of people have edema due to liver disease. What makes albumin? The liver, which makes almost every important protein in your body. Well, that isn't fair. That wasn't fair. Strike that. A ton of important proteins in your body made by the liver. So people who are getting albumin for edema probably have edema related to liver disease, and their liver can't make albumin, so they're trying to reset that balance. Ions charged. Was your hand up? I'm sorry. Are we just stretching? I thought your hand was just up. No? Yeah.
Oh, no.
No? Okay, sorry. Ions, charged elements. And ions are created only by changing numbers of electrons. If you lose an electron, you have a positive charge. You gain an electron, you get a negative charge. If you lose 2 electrons, you got a double positive charge. If you gain 2 electrons, you got a double negative charge. We're really going to be talking about single positives here. Sodium and chloride are your most abundant extracellular anions. Ions. One is a cation, one is an anion. Do you know the difference between those two terms? Positive, negative. Yep. Great way to remember is cation has a T, which looks like a positive sign. Okay, so sodium would be an abundant cation in extracellular fluid like plasma. Chloride would be your most abundant anion. Inside cells, potassium is your most abundant cation, and phosphate your most abundant anion. Why is sodium so abundant outside of cells and potassium so abundant inside of cells? The pump? Is that what you were saying back there? The sodium potassium pump? I like the way you all are calling it so funny. Like, there you have the pump. Is that what you all call it outside of class when you're talking about the pump to your friends? Thank you, Christian. Yep. Yep, just last Friday night, we had about an hour and a half discussion about it. Great, awesome. I like it. What else? Sodium potassium pump. I was going to remind you of that. Bicarbonate, calcium, proteins. These are other things that are in your plasma. I'm not quite sure how important it is to learn these until we get to a point to learn them. You should recognize them, and I am going to give you a blurb about calcium here in a second, but I'm not sure you really need to know about bicarbonate just yet. Language. Absorption. Where do you absorb most of the stuff that you absorb? In your intestines. Most of what I absorb into me is stuff I've eaten. Okay? You do absorb a little bit of stuff through your skin, okay? But for the most part, when you want to absorb amino acids and glucose and all the nutrients it takes to live, you eat them, and they get absorbed into your blood. We call that absorption, not reabsorption, because we're assuming that stuff has never been inside you before. Reabsorption is when something you have gotten into your blood has now gotten out and you're putting it back in. Like, for instance, does the healthy kidney ever pee glucose out? No, I should have said, does the healthy body? Because, quite frankly, kidneys can be healthy in early diabetes. You should never urinate glucose. And that's not that some of your glucose isn't trying to escape. It's trying. It gets down in the urinary tract like, oh my God, if I could just get through these tubules, I'm out of here, I'm out of here. The problem is, anytime is glucose useful to your cells? For making what? ATP, yeah. Glucose is one of those things that the kidneys have this permanent authorization. If you ever see a glucose molecule trying to escape through the urine, bring it back into the blood, because somebody will be able to use it. So that's what reabsorption is. Something in your blood accidentally oozes out into the urine, and your kidney takes it right back into the blood. Reabsorption. That's not the first time that glucose has been in you. By definition, if it was in your urine, it had to at some point be in your blood. In fact, anytime you think of anything oozing, leaking, pouring, flowing out of you, where did it come from? Blood, yeah. Sweat, urine, obviously mucus, snot. Anybody gross stuff yet? It was all in your blood at some point. It's all from your blood. What did CSF used to be? Cerebrospinal fluid. What did that used to be? Blood. Yep. Every fluid your body makes. Because isn't blood the river from which everything you get comes from and where all the stuff you don't want goes? That's like the creek in my backyard. No, not really. Not supposed to do that. How about not worrying about resorption and deposition? We're not going to talk about making bone, but secretion and excretion. Both of them mean getting out. But secretion usually means directly secreted from the blood. And that's what your kidneys do. When your kidneys want to get rid of something like hydrogen ion, they have the authority to go into the blood, grab it, and drop it in the urine to get rid of it. That's secretion. Excretion is when your cells actually make something that's supposed to be put outside of you, like sweat, mucus, digestive enzymes, stomach acid, stuff like that. That's all excreted. Finally, specific gravity is just a fancy term for urine concentration. Urine concentration. High specific gravity means urine is very, very concentrated. Low specific gravity means urine is really dilute. You should know those 4 things that cause edema, which is increased fluid in tissues. Now, a couple of them should come right from the discussion we just started with. Like, if I increase capillary hydrostatic pressure, that means I push blood through the capillary more. Is that going to push some more fluid out and cause edema in that tissue? There's your first one. What if I decrease the concentration in my capillary? I make it really, really dilute. It's not quite pure water, but it's really dilute. Now where does my plasma want to go? Out. Would that cause edema in the tissues in that area? So there's 2 that follow from that discussion. What if my capillary is really leakier than it's supposed to be? Whoa, look at that. That's some serious leakage. I didn't quite know what word to use there, sorry. Is more fluid going out?
Yes.
Would that cause edema in that area? Okay, now here's the tricky one. The tricky one is, and I don't, again, have a green pen. It doesn't matter. You all don't need colors. Okay, it'll just bother me. Okay, on the typical capillary bed, a healthy body is supposed to push some plasma or fluid out and regain most of it. Most of it, not all of it. It's supposed to get most of it back. That which is not brought back makes its way to the lymphatic channels, which course through your body and eventually return that fluid to the blood. If I block my lymphatics, which are basically a back alley drain for fluid that didn't make it back into the blood vessel, if I block those lymphatics, that also will cause edema because that excess fluid has nowhere to go. So there's our 4th cause of edema, lymphatic obstruction. 4 causes of edema. I want you to kind of make them make sense and don't just memorize them. Make those processes make sense in your brain. You'll be understanding a lot about how the body works. Okay, so now we get the big finish for this unit, and that is the hormones and the electrolytes and a little bit of compensation, and that's it. We're going to cross off a chunk of this handout, partly because it's redundant, and partly because I'm not sure treating, I didn't really spend a whole lot of time giving patients fluids. That would have looked really weird in the ME's office. You know, just put in a 14 gauge. I'm going to try and hold this thing. That would probably be it. That would have been the beginning of the career. Anyway, let's let people who know a lot about fluids tell you about some of the fluids we give people, how we give them, what these alterations are. I definitely know my hormones, so let's talk renin-angiotensin and aldosterone together. Again, this should be review. And if it's one of those sections that you kind of blew off in A&P and memorized whatever your teacher told you you had to and didn't really think about it, well, now you got to think about it. You've got to know how these systems work. It makes you understand the whole unit. So I usually start this by drawing some organs, kidneys and liver and lung. Okay. This is the renin-angiotensin system. And I will try to say or write everything you need to know about it. These are really the big points, okay? Big point number 1, and this is not unusual for the liver. It's not just this protein it does it for. But big point number 1 is your liver, just because it can, constantly supplies your body, your blood, with this protein hormone, angiotensinogen. Angiotensinogen. Angi means vessel, tensin means constrict. And who wants to tell me what the OGEN signifies? Inactive. Excellent. When we write a protein or an enzyme with a suffix OGEN, what that means is that it's currently in the inactive state. the liver is only secreting this and saying, hey, use it if you need it. If you don't need it, don't activate it, kind of thing. Right? Okay? So let's hope we don't need it. Well, sometimes you get either a low blood volume or a low blood pressure. And the organ in your body that's as good at anybody as sensing this, both of these, is the kidney. And if the kidney senses either or both, the kidney shoots out this stuff called renin. Renin. Renin is really what starts this. The angiotensinogen is just there. Nothing in this pathway starts until renin appears, and that's because the kidneys say, oh dear, low blood volume, or oh dear, low blood pressure, or oh dear, both low blood volume and low blood pressure. Okay? And what renin does is it converts angiotensinogen into angiotensin 1. Angiotensin 1. A very low active protein hormone, which doesn't survive for very long. Because once this starts circulating out into the blood, the lungs get whiff of it. Get whiff. It's the lungs. Thank you. Is an awesome joke, and it'll be even better next semester. It shoots out this stuff called angiotensin converting enzyme. Angiotensin converting enzyme, also known as ACE. I know, it's really cool initials. This converts angiotensin 1 into the active protein hormone angiotensin 2. And here are the effects of angiotensin 2 that I want you to remember. Effect number 1, vessel constrict. That's what the name angiotensin means. It causes vasoconstriction throughout your systemic arterioles. What does that do to your blood pressure? Yep. Good. Check that box. We needed to correct low blood pressure. We just increased it. The other thing this does is it tells your adrenal cortex to secrete aldosterone. Aldosterone. What does aldosterone ask my kidneys to reabsorb? Sodium. Sodium. Good. And when sodium is reabsorbed into my blood, since all my tissues are permeable to water, what follows the sodium into my blood? Water. What does that do to my blood volume? Check that box. So this system is how we correct low blood volume and or low blood pressure before you even realize you have a low blood volume or a low blood, you get it, back. Okay? Renin angiotensin. I could ask you, what does this conversion? I'd expect you to tell me renin. Or I might say, where does renin come from? I'd expect you to tell me the kidneys. I want you to know what two circumstances would kick this in. I want you to know what two effects. Does anybody know the kind of small third effect that angiotensin 2 has? Good, then we won't be confused when we get to antidiuretic hormone. Okay? And finally, aldosterone, which comes, it's right there in its own row, stimulates sodium reabsorption. I want you to also know that aldosterone, see, is sodium charged? Yes. That's the problem. When aldosterone asks the kidneys to reabsorb sodium, the kidneys say, fine, we'll open sodium doors, and if it goes down the concentration gradient into the blood, we'll let it. The problem is it's bringing a positive charge with it, and we need to either cancel that out with a negative charge or kick a different positive charge out. And aldosterone's choice on most occasions is to kick potassium out. So as the kidneys reabsorb sodium into the blood, they splash the potassium into the urine, so you get rid of it. Therefore, if you are secreting aldosterone, you are increasing your blood sodium and decreasing your blood potassium. Okay? You are, of course, also increasing your blood volume because water will follow sodium in. Most of that story should be review. Have any of you ever heard of ACE inhibitors? ACE inhibitors. Who do we give ACE in? What condition do we give ACE inhibitors in? High blood pressure. Okay? This increases blood pressure, this pathway. So a lot of people, this is just set a little bit too high. And as long as there's not a contraindication, we can give medications that block this enzyme, thus angiotensin II is never converted, their blood pressure goes down. I think this is the third or fourth most commonly prescribed class. Fluid pills, beta blockers, I can't remember what's next. I think it might be, anyone know? Please? Anyway, they're fairly popular, barring any contraindications. Yeah, good. Renin-angiotensin, everybody clear on that? Know where these things come from, know what does each conversion, know the overall effects. That takes us to another review, antidiuretic hormone, or ADH. ADH. Its other name is vasopressin, but I will always refer to it as antidiuretic hormone. I might even provide you all the parentheses, ADH. What does a diuretic make you do? Pee, yeah, we can say it. We're healthcare professionals. We can say it. It makes you pee, tinkle, wee-wee. I'm kind of keeping it clean today. Okay, so what does that do to my blood volume when I'm on a diuretic? Blood volume lowers because I'm peeing it all off. Well, an antidiuretic hormone, the opposite of a diuretic. So what does it tell my kidneys to retain? Water. What is that going to do to my blood volume? That's going to increase. This is your hormone for dehydration. When you have a low blood volume, antidiuretic hormone is secreted to primarily tell your kidneys reabsorb water, thus increase blood volume. Its other effect is to go to your brain and tell your brain that you are what? Thirsty. Yes. Technically, angiotensin II does that a teensy bit, but antidiuretic hormone, I want you to think of that as the thirst hormone. You all will see, has anybody heard of another diabetes, one that doesn't deal with insulin? That might, diabetes insipidus, good. People who don't have antidiuretic hormone. What do you think they do all the time? They do because they're peeing all the time, so their blood volume is low, and they're thirsty all the time. Does that sound a little bit like diabetes mellitus? Polydipsia, polyuria? Yeah. Thus the similarities. We'll talk about diabetes insipidus in Unit 3. Good. Then there's a disease where you have too much antidiuretic hormone. What do you think you look like then? You're all bloated. It's mostly water weight, but you're all bloated. Exactly. What do you think? How do you think we treat somebody who has too much antidiuretic hormone? Diuretics and don't drink water. Yeah, fluid restriction. Sometimes it's as simple as that. And try this little hydrochlorothiazide. You won't feel so bloated with water weight. Yeah, sometimes it works, sometimes it doesn't. Yeah, complicated stuff. But you'll see all this. These are common conditions. And of course, a city the size of Wichita, you're even going to see some of the really rare conditions. I mean, there's 750,000 people in the metro area. You're probably going to see some freakishly rare things once or twice in your career. But what are you going to see in most patients' charts? High blood pressure, diabetes, liver disease, poor diet. Okay, anyway. Natriuretic peptides. That's a hard word to say. Natriuretic. It hurts my mouth to say that word sometimes. But you know what? It's a combination of words. Natural diuretic. And these are proteins from your heart and brain that tell your kidneys to secrete water because your volume is too high. Natriuretic peptides. Questions on those hormone pathways? We'll stroll through memory lane. Just a lot of you just lip syncing right along. Yeah, I know it's not the most interesting stuff you studied before, but I will say this: the endocrine system is about as finite as it gets. That means you can put all the stuff you need to know in an endocrine system in the smallest box compared to all the other systems you need to learn stuff about. Really is finite to learn about it. They're complicated hormones, but they're finite. Okay, let's not worry about isotonic, hypertonic, or hypotonic fluid alterations. I just think that what I would be helping you with here would be redundant compared to our edema and our hydrostatic and osmotic pressure. So there's no reason to be redundant. Question?
To the aldosterone, because you have a note here saying aldosterone may be secreted independent of.
Good. This doesn't need angiotensin II to tell it to come out. Sometimes, if my blood volume and blood pressure are fine, but I have a little bit of a low sodium, aldosterone will be secreted independently by the adrenal gland to correct it. Thanks for pointing that out, and my apologies. Did everybody hear that? And I'm not going to try to trick you with this point, by the way. I definitely just want you to know these pathways and know what aldosterone does. But aldosterone doesn't need angiotensin II to tell it to come out. There are some conditions it can come out independently. But it does the same thing. Reabsorb sodium, get rid of potassium. Okay, so I also want to ask you about therapeutic fluid preparations. Okay, you all have heard of normal saline and lactated ringers, and that last one is dextrose 5 in water. It's like for people who are hypoglycemic, so you're putting some carbohydrate in their fluids for them. This is all about something you already know. Our blood is not pure water, so we don't put pure water into it. When we want to give somebody IV fluids, we want to give them fluids that are approximately the same concentration as their blood. Okay, and you all will get a lot better training than I can give you about therapeutic fluid preps. So let's just go on to the electrolytes and the big finish in this unit, starting with sodium. Sodium, the major extracellular fluid cation. If you all have ever seen a metabolic panel on yourself or anybody else, they often give you the normal ranges. Okay, and the normal range for sodium, it varies a little bit depending upon where you live, but it's typically in the 135 to 145 range. Okay, anybody know what the normal range for potassium is in blood? It's in the 3.5 to 5 range. So normal sodium blood, like if you took my blood and did a comprehensive, or just did a metabolic panel, just the simplest metabolic panel does sodium and potassium, you would hopefully see about a 140 sodium and a 3.5 potassium, and that would be normal. Even though in my body I have more sodium than potassium, but I've got about 2/3 as much potassium. Do those numbers sound like 2/3? 140 and 3.5. Is one of those tiny compared to the other? Well, you all have already answered this question. Blood is what? Is it extracellular or intracellular? Extracellular. So where is all the potassium in my body? Yeah, it's inside cells. Sodium potassium pumps, bringing it in cells. Good. Okay, so you should know that this is needed for membrane potentials and transport, water balance, and acid-base reactions. Again, if you're ever asked, what do we need sodium for? We need it to help set up our membrane potentials. We need it to help with our water balance. And we need it to participate in certain acid-base reactions, or I might have even said buffer reactions, but let's just stick with that acid-base. Reabsorption of sodium, this is again repeating, is promoted by aldosterone. Water will follow it in. We're pretty cool with wherever water wants to go. So it'll just follow sodium in. I will not ask you all to memorize symptoms of hyper and hyponatremia, but I want you to know what those two words mean. And they're pretty straightforward. Hypernatremia, high sodium, where? In the blood. Hyponatremia, low blood sodium. And one of the reasons I'm not going to ask you to memorize all those symptoms is, does it look like 3 of them are the same? Yeah. Whether you have high sodium or low sodium, you can be confused, you can have seizures, you can fall into a coma. And right now, we're just learning the pathophys. I don't need you all to be clinical experts yet. But eventually, you're going to have some clinical instructors that expect you to kind of know the consequences of too much or too little sodium, including symptoms and consequences of those symptoms the patient might have. I won't torture you over that here. Let's move on to potassium. This is the most abundant intracellular cation. Intracellular. So most of your potassium is inside your cells. Again, necessary for membrane potentials, that's all the sodium-potassium pump, and for certain metabolic reactions. These next 2 lines are really, really, really important. Uptake by cells, in other words, cells bringing potassium into them, is stimulated by those 4 things: insulin, aldosterone, epinephrine, and alkalosis. What does alkalosis mean? My blood has a high or low pH? High pH. Good. A shift out of cells is caused by pretty much the opposite of those things. Low insulin, low aldosterone, acidosis, and cell death is what cell lysis means. You may cross off exercise. So we got 4 on each row. Let's talk through these just very quickly. Let's rather than just memorize which ones uptake and which ones shift out. When a cell recognizes insulin, what message does that cell get? What is insulin telling it? Use the sugar, use the glucose, get you some. And what is the cell going to make from glucose? ATP. And cells that take up glucose to make ATP, does that sound like a cell that might be doing stuff? Making energy, using energy, oh yeah, I use that glucose, I'm doing stuff. And our cells that are doing stuff have maybe slightly busier sodium-potassium pumps? And which way does potassium go with respect to the sodium-potassium pump? It goes in. So uptake is stimulated by insulin. Just because glucose coming in, energy being made, let's get the pump turning up, potassium coming into the cell. 3 sodiums out, 2 potassiums in. Aldosterone. What does aldosterone want to increase in the blood? Sodium. And all the other positive charges, as far as it's concerned, should go elsewhere. Out or into cells. And potassium is one of them. So that's why aldosterone leads to an uptake of potassium into cells. How about epinephrine? What is epinephrine also called? Adrenaline. Does adrenaline sound like you're in a high energy state? And when you're in a high energy state, is the sodium-potassium pump working harder? And it's bringing what into the cell? Potassium. Finally, alkalosis, low blood pH. What am I needing in my blood if I have alkalosis? In a letter and a charge. Yes, acid is right, but what really is acid? Hydrogen with a positive charge. Okay? So when cells know that when the blood is alkalotic, cells try to give hydrogen to the blood. They try to pump hydrogen out. So here you go. But what charge does that have? It's got a positive charge. You can't just start shuttling positive charges without either sending a negative with it or bringing a positive in. So these cells bring a positive in. What do they bring in? Potassium. So there's why those four things, I don't expect you all to be able to write an essay about all those four things we just did. What I'm trying to do is help you not just rote memorize this, but look at this and say, okay, I can see why that's happening. And I know chemistry may not be our strong point, and even charges. When we start putting these little superscripts and subscripts on our letters, it's like, oh, okay, great. This is totally uninteresting. I get it, but I want you all to start understanding this a little bit. We've got to acknowledge charge gradients as much as we acknowledge concentration gradients. Okay? So let's look at the ones that take potassium out of a cell. Low insulin. Is that cell going to take up any glucose? So is it making any ATP? So it's pump busy. So a lot of potassium is hanging out outside the cell. It's just not a busy sodium potassium pump. How about aldosterone? If you don't have any aldosterone telling you to keep sodium high in the blood, is it telling you to keep potassium low in the blood? So potassium levels tend to increase a little bit outside of cells without aldosterone. Acidosis. Now, what's the problem in my blood? Too much or too low pH, which is too much what? Hydrogen. Yeah, it's got a positive charge. And now the blood is like, get in the cell, hydrogen. And the cell needs to exchange a positive out. It sends a potassium out. Exchanges hydrogen for potassium the other direction. And finally, cell lysis. Cell lysis. Normally, all your potassium is inside your cells. If you have a cell that dies, it breaks apart and spills out all the potassium. And all that goes into the blood. Okay, again, making sense of some stuff that is actually really a lot easier to memorize if it makes, at least if a couple of them make a little bit of sense. It's easier to memorize. Okay? Or another way to do it is memorize the first four and then the opposite is example. Kind of. I will not ask you all to know the symptoms, every symptom of hyper and hypokalemia. Again, we have some overlap, whether you're high or low. But I do want you to know what those two words mean. And again, we're talking about in the blood. Hyperkalemia, too much potassium in the blood. Hypokalemia, low potassium in the blood. Yes. I will not ask you about glucagon. Or cortisol, so you can cross out that row. Potassium. Not a whole lot of people are going to get too freaked out about a sodium that's mildly high or low, but you want to see a bunch of healthcare professionals, whether they're experienced or not, start freaking out a little bit. Start telling your patient has potassium at 2.9 or potassium at 6.1. That's going to get them a bed in a hospital. I don't care where you're from, because you got to sort that out. Potassium is when you don't want to wiggle too far outside of the normal range, because if it's when potassium is out of balance, its effect on your heart muscle. You can go into an arrhythmia very, very quickly with either high or low. That's why dysrhythmia is on both of those rows there. So very, very careful. They're also really, really careful about pH. They don't like people's pH getting too far out. And in fact, you all probably haven't really had this experience yet, but they even monitored in a female who's in even a low risk delivery, if they sense that the fetus has a low pH, they'll go into emergency mode. Immediately that's now a high risk pregnancy, and they're discussing the option of C-section if they have to, if they can't start controlling that fetal pH. So pH, potassium, another one that's really likes to be within normal range, calcium. Calcium. You don't want this getting too far out of its normal window. By the way, I will never ask you all to memorize normal ranges unless I specifically tell you to and they're in the handout. You all stay in healthcare long enough, especially as nurses and PAs and doctors, and you're going to have these little cards that go in your pocket with normal values. And you're like, oh my God, I got this card, so I always have the normal value of sodium and chloride and red cells and white cells. And your second day on the job, you'll never need this card anymore, because you have already looked at so many lab values with the normal range that you've got it memorized. But I don't think it's time to do that, so I won't ask anybody to memorize any insignificant or any non-significant normal ranges. Calcium is important for a lot of stuff. Obviously, bones and teeth. It participates in a lot of metabolic reactions, blood clotting, but its most important function for in my point of view, would be nerve and muscle function, contracting and nerves secreting, very, very important role there. Hypercalcemia is a word that means too much calcium. Hypocalcemia is low calcium in the blood. Don't worry about those symptoms except for one. I'll get to one each in a moment. What hormone manages your calcium? Is the boss of managing it? It's not pituitary, but it does begin with P. Parathyroid hormone. And that's what my hyper PTH is, too much parathyroid hormone, can lead to elevated blood calcium. Let's just know that parathyroid hormone's responsibility is maintaining calcium levels in your blood. Let's just know that much about the parathyroid hormone-calcium relationship. I won't ask anything about cancer or vitamin D or GI absorption here. Associate parathyroid hormone, though, with calcium management. And in hyper and hypocalcemia, since these are actually very helpful clinically, you should know that patients who have hypercalcemia too much tend to have weak muscles, like they're weak and almost flaccid, kind of. I just can't do anything. I'm trying to be floppy, and I can't even pretend to be floppy sometimes. And then hypocalcemia leads to a more spastic or tetany-like contraction, like I just wanted to do it once, and okay, now it's loosening up. Makes your contractions really tight, hard, and long. That's what tetany means. Like tetanus is where that actually word comes from. Tetanus is when all your muscles lock up. You all may have heard the term lockjaw. Sometimes their face will lock into this expression. They can't even open their mouth. So hypercalcemia is a more flaccid or weak muscles. Hypocalcemia, tight, spastic, tetany in the muscles. Let's not worry about the bicarbonate buffer. I don't think we need to review that, but I do want to put up for our last thing. Any questions on anything I've done so far? All right. Great. Let's do our last thing, and it's compensations. Again, I don't want to go through all the ins and outs of the buffer, so let's kind of talk, before we write down anything, let's just talk about breathing and CO2 and pH. So about how many breaths a minute are we all doing? I like that. 12 to 20, I think I heard a few of you say. That's a really good normal range. Okay, 12 to 20 breaths per minute. Okay, and at rest, for the typical human who's in a general state of good health, that's enough breaths at rest to get the oxygen required in for all the energy you need to do for that minute and to get all the CO2 out. But as you all learned in A&P, getting rid of CO2 is a trick. Our bodies actually make too much CO2 for simple diffusion to just get rid of it. So we have to disguise it and do a bunch of stuff to get all the CO2 out of our cells so that when I go and breathe out a bunch of CO2, I'm getting enough out so my cells don't suffocate in it. And what we did, again, I'm not going to ask you all to recapitulate this equation. This is just a reminder. What we learned was the bicarbonate buffer, which can go two ways. That's what my arrow means. This reaction can proceed in either direction. It can make CO2 and water from hydrogen and bicarbonate, or it can make hydrogen and bicarbonate from CO2 and water. Okay, that's what an enzyme in your body does. And in vein blood, where I have a lot of CO2, it converts CO2 and water into hydrogen and bicarbonate. That helps me get rid of more CO2 up to my lungs so I can go and get rid of a lot of CO2. Right? So you should think of CO2 and hydrogen as kind of being related together. Okay? This enzyme, its name is carbonic anhydrase. I put it in your handout or its abbreviation. You don't need to name it. It determines which way to go based on how much it has. If it has a lot of this, it'll start making this until it evens it all out. But if it has a lot of this, it'll start making this stuff until it evens it out. That's just how it rolls. So if I have a lot of CO2 in my blood, what is carbonic anhydrase going to turn it? And I always have water. I'm a bag of mostly water. So there's always water around. So if I've got a lot of CO2 in my blood, what will the carbonic anhydrase turn that into? Bicarbonated hydrogen. What does this do to my blood pH? It lowers it. So if I just stopped breathing, I'm breathing with my nose. Okay, so I'm cheating. But if I really did stop breathing, am I going to retain a lot of CO2 that I'm supposed to be exhaling? And that's going to build up in my blood? And all my carbonic anhydrases will turn it into this stuff? And what will happen to my blood pH? It will go down. So I want you to get that relationship. If I don't ventilate out my CO2 effectively, my blood pH is going to get low. I'm going to have an acidosis in my blood. But on the opposite of that, what if I, at rest, just decide to start going like this for no other reason than I just want to? Can I do that for very long without fainting? I can't. Why? Too much CO2 for the activity level I'm in. Good. What's that going to do to my blood pH? Now that this doesn't have any CO2, it's got more hydrogen and bicarb. It will convert all that to CO2. So what will happen to the hydrogen in my blood? It will go down. So what about my blood pH? And now I have an alkalosis, just out of deciding to hyperventilate. Okay? What happens, what are you supposed to do if you get on an airplane and you're about to go on vacation and somebody you've never met before sits next to you on the airplane and you're about to taxi off and take off on your vacation, and this person just decides at that moment to share with you, I've never flown before and I think I might be really scared. And then they start hyperventilating. Switch seats. Me too. Me too. I need another seat. But the compassionate healthcare professional would tell that person to do what as they start to hyperventilate? Get a bag and breathe into it. Now, let's think about what happened to me when I was hyperventilating. I was blowing off too much CO2. My blood pH was getting too high. I could pass out and hit my head on the corner of this metal thing if that happened. I want to avoid that. So I give them the bag. They breathe back in their own CO2. Is that going to kind of control this now and balance this? So now my pH won't get too high with blowing off that CO2. That's why. That's why we give them a bag. Let's think of something else here. What if I decided? I forget how much because I used to know exactly how much of every pill you're allowed to take and it be toxic and. I don't know anymore, but let's just say I decide to take 9 aspirin. Is that a lot?
Yeah.
What's the normal dose?
2 to 4.
2 to 4. I'm like adult 325 milligrams. Really? I'll take one of those.
81 milligrams.
I have some stomach acid issues. Anyway, what's the other name for aspirin? Anybody know? No, that's its cousin. Salicylic acid. It's an acid. And I take 9. That's too much. There's no label that tells you to take 9 aspirin. That's not going to kill me. But what did I just add a lot of to my blood? Acid, hydrogen, this. What's this going to turn it into? CO2. And you know what I'm going to automatically start doing? I might not even realize I'm hyperventilating, but it's my body's way of blowing off that excess acid. And this happens clinically in diabetic ketoacidosis. If an undiagnosed type 1 diabetic has too much unused glucose, does that person need to make ATP? But they're not using glucose? You know what the body does in that case? In undiagnosed type 1 diabetes, no glucose is being used to make energy. What's happening is the body doesn't know the glucose is in the blood, So the body goes and looks for proteins and lipids that it can break in half and run through this really complex chemical reaction to turn into glucose so that it can make ATP. And the byproducts of those reactions are acids. We call them ketone bodies. They're acidic. So as that happens, my body is making its own glucose, not using the glucose that I ate. The byproduct is acid. That patient's pH is getting really low in their blood, and sometimes these kids come in with what we call Kussmaul respirations. They're literally hyperventilating loud and deep, like they're sucking air, but all their body is trying to do is blow off all of that acid. One dose of insulin, and it goes away. Literally one dose. Okay, so I just wanted to introduce it. This is going to make our story of compensations make a lot more sense now if you feel like you're gaining an understanding of this balance, your CO2 and hydrogen balance. This is the story of compensating either with your lungs or your kidneys for a pH imbalance. And unless I specify, we're always talking about the blood, because the blood is the most important stuff that's inside you. We want to look inside you. What do we look at? Your blood. Acidosis and alkalosis. One of them is too much hydrogen. One of them is not enough hydrogen. And here's the game we play. I'm going to give you one of these two words with one of these two words. Metabolic or respiratory. This word means it's not the lungs' fault. This word means it's the lungs' fault. Anything but the lungs caused the acidosis or alkalosis? The lungs caused the acidosis or alkalosis. If the lungs caused it, can we expect them to fix it? No, that doesn't make any sense. But if something else caused it, and we can assume the lung's healthy, will they help fix it? Good, that's kind of the point of the game here. So if I give you, the first word in my condition is metabolic, you know that the lungs are going to try to fix it or compensate. So I can give you metabolic acidosis or metabolic alkalosis. My message there is, first, I'm going to give you the pH abnormality, and I'm telling you it's not the lungs' fault, so they'll fix it. So what could the lungs do to fix too much hydrogen in my blood? Hyperventilate. The respiratory compensation here is hyperventilate to do what to pH? What do I want to happen to my pH? Do I want to go up or down? Careful. It's too low, acidosis, so I want it to go up. Don't let that trick you. I want you all to write this stuff in the margins of your exams, because when you start doing stuff like this in your head, one backwards flip and it's the opposite answer. Okay, so just be really, really careful with these. What if, on the other hand, I gave you metabolic alkalosis? Now what might the lungs do to change this? Hypoventilate. Now I'm going to hold in some of my CO2. This will convert that to hydrogen, and that's what I'm lacking. I'm low on hydrogen. So the respiratory compensation here is hypoventilate to lower pH back to normal. Clear on that road? Literally, I'm going to give you a pair of words. Metabolic acidosis, metabolic alkalosis, and I want you to be able to tell me what is the correct compensation that will occur. Now, on the next row, it's a respiratory problem. So in this case, the lungs have caused the pH imbalance. We probably can't expect them to fix it. So remembering from your A&P, what other organ can help us adjust blood pH? Kidneys. So we now no longer call this a renal compensation, or we no longer call it a respiratory compensation. we are going to look to the kidneys. We call it renal compensation. Can the kidneys hyperventilate and hypoventilate? That's ridiculous. They don't breathe. Very weird, like inflating the bladder, deflating, inflating. You know that when they do do you all know what a cystoscopy is? What am I looking at with a cystoscopy? Bladder. Yeah, would they literally go up the urethra? Am I breaking any tissue to do that? No. And you know what they sometimes do to get a better look? They blow some air in there and then inflate it. So, kind of breathing. They do that all the time. Have you ever heard of an exploratory laparoscopy is how you're supposed to say it. You know what that is? They don't know what's wrong inside you, and they don't want to start cutting you up and digging around until they do know. So they just poke one hole in, shoot a camera with a light in there to look, but it's all crowded in there. So what do I need to put in there to get a better view? Yeah, inflate it. It's pretty cool. You don't hold that button down for too long. It'll keep inflating. Well, okay, so all right, that's silliness. I'm really just trying to kill time, get us to 7:30. If the kidneys can't ventilate, what can they do to maybe help me get rid of some hydrogen? Can they secrete? Let's go with secrete. So the renal compensation here would be to increase hydrogen secretion. I have too much of it. Let's get rid of some of that extra. To actually measure the pH of someone's urine to assess this compensation. Like in somebody who has emphysema, that oftentimes leads to a respiratory acidosis, and their urine just chronically gets a teensy bit more acidic because their kidneys are getting rid of that excess hydrogen. Over here, now this is one to be careful with. We're also going to renally compensate respiratory alkalosis, but the kidneys do not have the authority. The kidneys have a lot of authority, but they do not have the authority to reabsorb hydrogen. So the best they can do over here is, okay, I'm low on hydrogen. The way the kidneys compensate for this is they simply stop secreting it. Say the best that I can do is I won't pee any out. Okay? 2 renal compensations for respiratory pH imbalances, 2 respiratory compensations for metabolic pH imbalances. Oftentimes, like in that situation where I took the 9 aspirin, since that stuff would be in my blood for a while, the real story is I would probably ventilate most of that off, but probably my next 2 times to the bathroom to pee, I would probably have slightly acidic. So there's a lot of times when these 2 will work a little bit together to correct a pH issue, but I want you to think of it as one or the other based on the words I give you. And that's that row that says, compensations and stuff. Make sure I covered it. And I think that's the end of the Unit 1 handout. Unless you want me to add more. You want more? No, it's not. I don't really know what I talked about. I'm not tossing anything out. I think we had a really nice, good, solid Unit 1. I have high expectations. Now remember, the exam is not Thursday. We will start Unit 2 Thursday. Did I post that handout yet? No. What's the secretary been doing? I don't. I'm getting a secretary in 32 years though. So. Yes, sirs. All right, well, have a great evening, and we'll talk about what rooms you all will be in for exam night on Thursday. Exam is next Tuesday night. Don't forget your recorders and devices.